Good afternoon, audience, or good morning, depending on which part of the world you are logging in from. Last 4 days, today included, we have been discussing about how to take care of the colorectal cancers, and you have already had the lectures in which the diagnosis, the initial signs and symptoms, the pathology and the surgical aspects have been discussed in great detail. Like many other solid tumors in the body, depending on the stage that we are in, colon or rectal cancer can be a local treatment, a regional or a distant disease. And in that context, today's lectures will focus on both the regional as well as the systemic treatment of the colon and rectal cancers. Now, one of the key interesting thing about rectal cancers is that unlike many other cancers in the body, the non-surgical adjuvant treatment actually precedes the surgical treatment. And in that context, the first speaker today, Dr. Sashikaran, will discuss with you about what is the role of radiotherapy, how it is given, when it is given, and how to assess the response at the end of radiation before surgery. Dr. Sashikaran, please.
Thank you, Dr. Kaushik. Good evening, everyone. It's a pleasure to be here and to talk to you today about the role of radiotherapy in rectal cancers. So the topics that we'll be going through this lecture include where exactly does radiotherapy come in as part of management of rectal cancers, the timing of radiotherapy, whether it's better given neoadjuvant or in the adjuvant setting, the duration, whether a short course is better or a long course, what variations and combinations are we looking at, techniques, toxicities, response assessment, and follow-up. So having discussed in the previous lectures about baseline assessment, just to summarize them because this will help us, a reflection of this will be again back towards the end of the lecture in response assessment. The first and foremost in any diagnosis of any cancer is a clinical examination, of which digital rectal examination plays a major role in determining the distance from the anal verge. A flexible sigmoidoscopy is vital, especially to confirm the diagnosis with a biopsy. The next is to confirm and stage the malignancy in terms of T, N, and M stage. And within that, the T stage in early stage rectal cancers, and endorectal ultrasound plays a major role. It helps in determining the depth of invasion, whereas once the tumor has gone into the mesorectal plane, an MRI plays an important role. The nodal stage as well is just as well documented in an MRI. And to rule out the presence or absence of distant metastasis, a PET CT scan or a CT scan is done for completion. So once you've done all of these steps, you then stage the cancer based on the TNM classification. And within this complex classification, where do we actually require radiotherapy? Now, early stage rectal cancers in situ T1, T2 or N0 can be managed with single modality, which is surgery. Some of the very early cancers can be managed with micro-invasive surgeries, whereas the stage 2 and stage 3, which are considered as the locally advanced rectal cancers, require multimodality treatment. So that includes radiotherapy, surgery, chemotherapy in various sequences and combinations. Stage 4, which is metastatic disease, will be covered in the last lecture, and this predominantly is systemic therapy. So what exactly established the need for radiotherapy? Early in the 2000s, the Dutch conducted many studies. One of the prominent studies involved over 1800 patients, where they randomized patients to preoperative radiotherapy, 25 gray and 5 fractions, followed by a total mesorectal excision within a week's time, versus another group where they had surgery alone. So in this study, they came to the conclusion that there was a significant reduction in local recurrence in the group that received radiotherapy prior to surgery. And this therefore established the role of radiotherapy in rectal cancers. So the first question being answered, we'll go to the next question. Now, what would be the appropriate timing for radiotherapy? Is it in the preoperative setting or the postoperative setting? Now again, various studies, this is a very busy slide, but just to summarize, 3 main studies, one from Germany, an NSABP study, and MRC CR07. They looked at a randomized comparison of preoperative radiotherapy versus postoperative radiotherapy. And just to tell you in brief what they concluded, there was improved local control with preoperative radiotherapy, less acute and late toxicity with pre-op RT, and no difference in overall survival. So the second question is answered. The best timing for radiotherapy is in the preoperative setting. The third question, is a short course better or a long course? So when I say short course, what exactly does that mean? Now, a short course of radiotherapy is practiced predominantly by the Dutch, where they gave a high dose of 5 Gray every day over a period of 5 days. And within a week, this was followed up with surgery. Now, the rest of Europe followed a slightly different technique and rationale. They used a small dose per fraction every day, which is protracted over a period of 5 weeks. And they added in oral or IV chemotherapy, with the rationale being that this could further improve the response rates and clinical PAT-CR rates. And in this case, surgery was followed up 4 to 8 weeks later after all the side effects settled down. So there are a couple of randomized studies which looked at comparing the short course versus the long course. And one of these was from Poland and another was a TROG study. Again, we won't go into too much of detail, but just to summarize what they came up with. Now, the short course versus long course, there wasn't any difference in sphincter preservation rates, no major difference in overall survival or disease-free survival, no difference in local control. However, one of the studies showed a trend to improve local control with the longer course radiotherapy in distal tumors. So again, to answer the question of what duration is best, a short course can be done in most cases, but a long course is possibly preferred in distal tumors. Then are there any more variations and combinations apart from just these two schedules? Yes, there are. What they've tried to do is, one group tried to increase the gap between radiotherapy and surgery. Another group tried to add in chemotherapy in the gap between radiotherapy and surgery. And another group tried to omit surgery completely in a select group of patients. So the gap between surgery and radiotherapy, as I said, is traditionally 1 week after a short course treatment and 4 to 8 weeks after a long course treatment. But studies did show that there were better PAT-CR rates by increasing the gap. So the STOCKHOLM III trial looked at lengthening this duration from 1 week to 4 to 8 weeks, and they also compared it with a long course schedule. And they concluded that there were better PAT-CR rates in short course radiotherapy with delayed surgery. There were also less post-op complications in this group. However, there was slightly more post-radiotherapy acute toxicity in this particular group. Now, the second approach is throwing in chemotherapy in that waiting period. This is called as a total neoadjuvant treatment approach, and this will be discussed in great detail in the next lecture. The third approach is what we call as watch and wait. Now, Haber-Gama did multiple studies with the case series of patients where they received long course chemoradiotherapy, and within 8 weeks they were reassessed with an MRI, digital rectal examination, sigmoidoscopy and multiple biopsies. And those patients who had a complete clinical response actually did not undergo surgery but went on to a very close period of follow-up. Whereas those who did not have complete response went in for standard surgery. So with this particular approach, they found that at 8 weeks, up to 49% achieved a complete clinical response. However, 31% developed local recurrence in future follow-up, most of them within the first 1 year. But fortunately, 93% could have salvage surgery. And the 5-year overall survival was as high as 91%. So the only problem with this schedule is that patients have to be very compliant with a strict follow-up protocol. And this can maybe be considered in a select group of patients, but more data is required for this to become standard of care. Now, to just brief you about the technique of radiotherapy, the first step in radiotherapy is to immobilize a patient in a comfortable position. We then do a CT scan called a CT simulation, which helps us to identify the target volumes, and we utilize all of the pre-treatment information, clinical PET and MRI to doing this. Once the target volumes are identified, we then go through multiple plans by using beams targeted from multiple directions or an arc, and a plan is generated in order to deliver dose to the target volume and spare normal tissues. Treatment is then delivered under daily image guidance. So like every good thing also comes with its problems, radiotherapy also has side effects. The acute side effects include diarrhea, hematological effects when you add in chemotherapy, dermatological effects, and long-term side effects include gastrointestinal problems such as adhesion, subacute intestinal obstruction, rarely strictures, bladder and other genitourinary problems. Now coming to response assessment, this is basically what you do at baseline is repeated for response assessment. You do a digital rectal exam, an MRI, a completion colonoscopy if not done prior to radiotherapy, and a CT scan of the chest or abdomen to rule out distant metastasis. And once you assess response, now an MRI is very, very important because it assesses tumor regression grade. It can very accurately predict what you're going to find in your pathological specimen. And more importantly, an MRI serves as a surgical roadmap for sphincter preservation. For example, this patient pre-treatment had sphincter involvement, but on the post-treatment MRI, there is complete fibrosis in the sphincteric region, and this could potentially spare this person's sphincter. And coming to the end of everything, once all of the treatment is over, surveillance needs to be done for the first 5 years at a frequency of 3 to 6 months for 2 years, and then 6 monthly thereafter until 5 years. A history and physical CEA and a CT scan could be done once every 6 to 12 months. And with all of this information, if you're completely confused, let me just summarize everything for you. So what are the indications, or where does the role of radiotherapy come in stage 2 and stage 3 in most patients? The timing of radiotherapy that's most appropriate is when it's given pre-operatively. Duration of radiotherapy, both short course and long course are valid options, but short course with TNT is an emerging option for more advanced cases. And the variations and combinations, again, TNT, wait and watch approach. And we've talked about the technique, toxicity, and response assessment. With this, I conclude. I thank the GI team for giving me this opportunity, and I thank my colleagues, Dr. Kaushik Bhattacharya and Sujana Priya, for the content of this lecture. Thank you.
So, thank you, Dr. Shashikaran. That was a very nice and short summary of the role of radiation in rectal cancer. I'm particularly intrigued about the fact that you have an option of significantly curtailing the duration of the treatment, which is possibly not there in most of the sites in radiation. And do you think that there is some lesson or the takeaway for Indians, where many of the Indians have to travel long distance to access the service of radiation oncology because it is not as widely available? Do you think it is particularly helpful to have the treatment duration shortened to only 5 days in the context of our socioeconomic situation?
Absolutely. I think it's very relevant to our population because waiting or staying in a certain place for a month or a couple of months may be a deal breaker for some patients. They sometimes just go away because of the financial or the logistic implications. So I think a short course treatment, apart from just serving the logistics of a patient, like I said, outcome wise as well, is almost as good as or just as good as a long course treatment for most patients. So I think this is a very valid option, and more so in the Indian context.
So thank you for that clarification, and also I'm very glad to know that in your practice you have been able to adopt that short course in a very meaningful way, and a significant number of your patients are actually receiving a very short course which is equivalent. Also, what I found very interesting in your presentation is the mention of the fact that there is a benefit of finishing not only the radiation but the chemotherapy as well before the surgery. So I would invite my next speakers, Dr. Sujana Priya, to throw some more light on that as to what are the different options of finishing the whole treatment, adjuvant treatment before the surgery is done, what are the gains, what are the pitfalls, and how does it work really? Dr. Sujana Priya, please.
Thank you, Dr. Kaushik. My topic for today is total neoadjuvant therapy in carcinoma rectum. It's rather an emerging and a very novel topic in managing CA rectum patients. So let's dive deep and see the evidence and the indications of short course and as well as total neoadjuvant treatment in CA rectum. So my scope of presentation today will be like this. We need to know what exactly is total neoadjuvant treatment, the definition and rationale of total neoadjuvant treatment in carcinoma rectum, and the evidence behind the total neoadjuvant treatment as well as the current guidelines. So before we go into it, I think we need to get some facts straight and also the definition of total neoadjuvant treatment. The other day when I was talking to one of my colleagues, they had a little bit of confusion thinking that total neoadjuvant treatment is nothing but a wait and watch approach in CA rectum. So that is not the case. That is the reason we need to get our definitions correct. So TNT is nothing but a novel approach for locally advanced rectal cancers, wherein we deliver both radiation and chemotherapy before surgery. That doesn't mean that we are trying to avoid surgery at any cost. Rather than defining it theoretically, let me show you a nice flowchart. So as my other colleague Dr. Nandita has pointed out in her previous lecture, the first step in locally advanced rectal cancers will be radiation, either in the form of long course or short course. The second step would be surgery, and the third step is depending on the histopathological features will be adjuvant chemotherapy. But what are we doing in this total neoadjuvant treatment? So the first step will not change. It will be definitely radiation in the form of short or long course. The second step will be chemotherapy, and the third step will be surgery. Last but not the least, putting surgery in the end doesn't mean that we are trying to avoid it, but there is a good rationale behind why we are trying to adapt total neoadjuvant treatment in treating rectums. So long before, in the early 1990s, when total mesorectal excision came in vogue, before that, so the locoregional recurrence was always a problem when treating rectal cancers. Once the newer surgical technique like total mesorectal excision has come into play, the locoregional recurrences have drastically gone down. In the last decade, if you see, it's almost only 5% as per data. And what exactly is the background and aim as to why we are slowly adapting and going towards total neoadjuvant treatment? So the DFS, the disease-free survival in locoregionally advanced cancer is less than 75% because of distant metastasis. The aim here is to treat the distant disease but not the local disease. You have to reduce, the aim is to reduce the distant metastatic disease as well as local control in the locoregionally advanced rectal cancer. The effect of adjuvant chemotherapy has not been clearly proven in rectal cancers. Most of the data what we have is being extrapolated from colon cancer. And also after undergoing major surgeries like LAR or APR, there is a very less compliance rate of the patient in taking adjuvant chemotherapy. After delivering short course, if you give a long gap, so the downstaging is better, and definitely the PATCR rates are going to be better because the effect of radiation is going to act and it's going to take a while. So now let's look at different treatment combinations, and I'll be talking about different evidence. So we'll look at different treatment combinations. So this is a very interesting and the latest trial published in December 2020. It is acronymed as a RAPIDO trial, but it is actually, the full form is a rectal cancer and preoperative induction therapy followed by dedicated operation. So total of 920 patients have been enrolled in this trial. Most of the centers participating countries were in Europe, and a few centers have also been taken from US. So let's look at the inclusion criteria of this trial. So more than 18 years old with good performance status, and MRI is a mandatory investigation in this RAPIDO trial. So based on the MRI, if you have more than or equal to one of the following risk factors like T4A, T4B, EMVI positivity, enlarged lateral nodes, N2 disease, and MRF positivity, these are all considered as high risk factors for distant relapse. So let's look at what is the exclusion criteria. So the decision of undergoing a surgery after treatment should be made in the first instance in the MDT. You cannot say that you cannot operate after giving all the total neoadjuvant treatment, because that is not how this trial was planned, and that's not how we intend to do it. So whenever the tumor is extending into lumbosacral roots, it is definitely inoperable in the first go. So that is an exclusion criteria. So metastatic disease, patients with IBD and known DPD deficiency, because these patients cannot tolerate capecitabine, and any contraindication to MRI because the staging should be done using an MRI, and there is no other go. Any patient with who is pregnant or breastfeeding, because RT is an absolute contraindication, malabsorption syndromes and history of peripheral neuropathies and cardiac disease, these all patients have been excluded from this trial. Now let's look at the study design of this trial. So this is a two-arm studies with equally distributed patients in both the arms. The standard of care arm is the 5.5 weeks of radiation, following which after 8 weeks the patient undergoes surgery, after which depending on which institute you are and depending on your institutional protocol, you either go for adjuvant chemotherapy. And how is this experimental arm designed? So you just receive only 5 days of radiation. So you have to make a note, 5.5 weeks versus 5 days. That makes a lot of difference to the patient. Following which after 11 to 18 days of treatment, you go ahead and start off your chemotherapy. And after you finish your 6 cycles if it is Capox or 9 cycles if it is Folfox, you go ahead and operate after 2 to 4 weeks. What are the endpoints they have looked at in this trial? The primary endpoint is the disease-related treatment failure, and the secondary endpoints are overall survival, resection rates, toxicity, and quality of life. There is definitely an improvement in the disease-related treatment failure at 3 years. We'll look at the graphs and Kaplan-Meiers in the next upcoming slides. So most of the patients in this trial, almost close to 70%, most of the patients are male population. The median age is around 62 years. And with good performance status patients taken in this trial. So the high risk criteria, what we spoke about in my previous slides, the mesorectal fascia involvement and the N2 disease comprised of most of the population in this trial. So looking at the disease related treatment failure, it is definitely lesser in the experimental arm, the short course arm, and the distant metastasis is also definitely lesser in the experimental arm. But there was no difference in the loco-regional failure nor the overall survival. But anyhow, this trial was not designed for that. These are all the secondary endpoints. So most of our oncology colleagues or the referring physicians, most of them are scared about the toxicities because we are only giving radiation in 5 days, that too with a very, very high dose. But as per this trial, there are really not very notable complications nor side effects during the course of treatment. The important and major side effects with some significance were neurological toxicity, vascular disorders, and diarrhea, which is more in the experimental arm as expected because we have given a very high dose in 5 days. But these patients never went into a very debilitating condition, nor this dose or this complication is extremely moribund. It can be managed in the hospital with admission for a couple of days, and after which you can easily breathe through. Coming to the pathology of the resected tumors, this has got nothing to do with any systemic disease. But once you analyze the pathology between the experimental arm and the standard arm, definitely the R0 resections with greater than 1 millimeter distance from circumferential resection margin is better in and also the path responses, the pathological complete response is better in the short course arm. It is almost doubled. So this can be attributed either to radiation as well as chemotherapy after radiation in the total neoadjuvant treatment arm. So, what are the take home messages in this trial? The 7% lower disease related treatment failure, and also the lower distant metastasis rate and doubling of the PAT-CR rates, which is very, very important and was also statistically significant. There is no change in the overall survival. There is no unexpected toxicity nor it didn't affect any quality of life. Let me quickly walk you through one more interesting trial called the PRODIGE 23 trial. So this is also a very interesting trial where, again, as I already spoke about, there are a little changes and a little bit of permutations and combinations as to how these trials were designed. The inclusion criteria were the same, all the loco-regionally advanced cancers go into this trial. But coming to the total neoadjuvant treatment arm, they have used FOLFIRINOX in the first instance, following which they have given a radiation. So the radiation has gone into step 2 in this PRODIGE trial, following which the patients have undergone surgery, and after which they have continued 6 more cycles of chemotherapy. Again, the endpoints are disease-free survival and other secondary endpoints like toxicity, pathological response, and quality of life. The disease-free survival is definitely better in the total neoadjuvant arm as well as the metastasis-free survival. To conclude, FOLFIRINOX is also a safe regimen. Not only Capox, you can use FOLFIRINOX also based on the PRODIGE 23 trial. It increased the possibility of path response rates and also the curative intent of surgery, and also they have improved the disease-free survival. So coming to the next most interesting trial, it was published recently. It's a Chinese trial published from Beijing called the STELLAR trial. So the study design is somewhat a little different, again a little somewhat different from what the other trials are what I've spoken about before. Again, they have given some short course radiation, following which after 1 week the patient is being started on Capox regimen for 4 cycles, after which the patient undergoes surgery and then will go ahead and take 2 more cycles of Capox. So you're not wrong, you're just trying to do some permutations and combinations and trying to derive the best treatment approach for the patient. So the disease-free survival, there's not much difference between disease-free survival. This is only 3-year data of this STELLAR trial. In this 3-year data, the 36-month data showed a little leaning towards improvement in overall survival, but I think we should take that with a pinch of salt, and we need more mature data from this trial. There's no difference either in metastasis-free survival nor locoregional recurrence. And these are the 3 important total neoadjuvant trials which have been published recently in the last couple of years. So based on these trials and scientific evidence, the ESMO guidelines as well as the NCCN guidelines have incorporated short course treatment along with total neoadjuvant, along with chemotherapy as a total neoadjuvant treatment approach. These guidelines are considered extremely sanctimonious for the oncology crowd, and a lot of oncologists are slowly moving towards this short course treatment with neoadjuvant chemotherapy, the total neoadjuvant approach. So whenever you discover something new in science, the important question, the most important thing is you have to provide a new question rather than expecting a new answer. The final take-home message is definitely TNT is better because of the patient convenience and logistics, because you are giving a short course in combination with neoadjuvant chemotherapy. Choosing the right patient is the key based on whatever investigations you do, and the caution is MRI is the key, and you cannot just get away with doing a CT or ultrasound and just with a biopsy report. So there is an argument from the surgeons that delay in surgery might increase a little bit of morbidity in the time period where you give chemotherapy, but that is not scientifically validated nor proven. So some studies have advocated doing an interim surgery in non-responders or poor responders. Yes, it is very strongly validated also, because there is no point in continuing a neoadjuvant chemotherapy if the patient is not responding to treatment. So this is also a very, very good option in resource limited settings. Because the patients doesn't have to stay for a very long duration for radiation. I hope I've made this lecture very interesting with all the scientific evidence. Thank you so much.
Thank you, Dr. Sujana Priya. I think you have summarized what is possibly the most new and ongoing change in the management of rectal cancer. Now, the key 3 trials that you mentioned are from France, Poland and China. And I understand that in India, the few centers that are actually adopting this approach of giving total neoadjuvant treatment, one of them is yours.
Yes.
And what is your preliminary experience about the tolerance of such a treatment and the logistics convenience of this treatment in the context of Indian patients?
So in the last 4 years when we started the department, the initial treatments were, most of the treatments were long course, because that time we were really, we were looking a little skeptically at the total neoadjuvant treatment approach as well as the short course treatments. But nowadays most of the patients what we are looking at are receiving short course, and they are very, very happy because of the logistic reasons. So coming to the toxicity part, we have a nurse administrator, and we have been clearly monitoring all the acute toxicities, and we have never seen any grade 3 toxicities, God forbid, till now. So I think this short course and total neoadjuvant is very much in vogue now, and I think it should be followed for patient convenience.
So thank you very much. And while neoadjuvant or total neoadjuvant forms a significant part there is also a significant section of the patients who will continue to receive their chemotherapy after the surgery is over, not just for rectum, a significant portion of them for colon cancer. And I would request Dr. Janardhan to focus on how the role of adjuvant chemotherapy, that is after the surgery, plays out in colorectal cancers.
Thank you, sir. Good evening, everyone. So I am going to focus mostly on adjuvant chemotherapy for colon cancer patients. So these are the various factors that we should take into consideration when we decide upon adjuvant therapy in colon cancer patients. So the first and foremost is the risk of recurrence. The second one is the expected benefit from adjuvant chemotherapy, and the third one is the risk of toxicity. So coming to recurrence risk assessment, so data shows that 5-year survival rates after surgical resection alone is about 99% for stage 1, 68 to 83% for stage 2, and 45 to 65% for stage 3. So stage 1 patients go into observation. The role of chemotherapy comes mainly in stage 2 and stage 3 cancer patients, wherein we are looking at increasing this 5-year survival rates. So the recurrence risk is estimated by integrating the clinico-pathological features of the tumor along with the molecular marker, that is MMR or MSI status. Whatever said and done, TNM staging remains the most relevant histological criteria for risk assessment. So when we look at intermediate stage 2 patients, we know that they have got a variable prognosis, and hence we need to incorporate multiple clinico-pathological parameters in refining the risk stratification. So coming to risk factors for stage 2 risk assessment, we have major and minor risk factors. So we have two major risk factors. One is the presence of less than 12 lymph nodes in the surgical specimen, and pathological T4 stage including perforation. Minor risk factors include the presence of high-grade tumor, the tumor with vascular invasion, lymphatic invasion, perineural invasion, or if the tumor presents with obstruction, or if there is presence of high preoperative CEA levels. So data has shown that adjuvant systemic therapy decreases the risk of death, and the absolute benefit is in the range of 3 to 5% in high risk stage 2 colon cancer with single agent 5FU, and it is about 10 to 15% in stage 3 disease with 5FU alone, and there is further 4 to 5% improvement by adding oxaliplatin. So moving on to MSI testing. So it is the most validated prognostic molecular marker used in deciding adjuvant therapy, only next to the clinical prognostic factors. So we have two methods of testing MSI. One is the immunohistochemistry, wherein we detect the loss of MMR protein expression. The other method is by polymerase chain reaction. See, the objectives of MSI testing is to find the prognosis and the prediction of adjuvant benefit, and to determine the potential genetic predisposition. So the MSI status is important in ruling out the diagnosis of Lynch syndrome. So if there is a loss of MSH2 and or MSH6, it indicates a suspicion of Lynch syndrome, which should be confirmed by doing a germline mutation testing. So if there is a loss of MLH and PMS2, then there should be further investigation for BRAF mutation or hypermethylation of the promoter region of MLH1. And if either of this aberration is present, then it is most likely due to a somatic mutation rather than a germline mutation, thereby ruling out diagnosis of Lynch syndrome. So MSI status identifies a subgroup of these patients with a better prognosis and less expected benefit from chemotherapy. So now let's move on to stage 3 disease. So the current standard of care is a combination of 5FU and oxaliplatin. So we have 3 landmark trials, the MOSAIC, the NSABP CO7 and the Xeloxa trial. So these compared the combination of 5FU and oxaliplatin against single agent fluoropyrimidine, which was the previous standard of care. So all these trials showed a significant improvement in the disease-free survival. So looking at the therapeutic regimens used in this trial, MOSAIC used a infusional 5FU, whereas NSABP used a bolus 5FU regimen. Xeloxa used a bolus 5FU against Capox regimen. So the MOSAIC and NSABP trial included both stage 2 and 3 cancer patients, whereas Xeloxa included only stage 3 colon cancer. So all these trials have shown that addition of oxaliplatin resulted in similar reduction in the risk of recurrence So it was 23% in MOSAIC, 20% in NSA-BP and Xeloxa. And longer follow-up data has shown that there is improvement in OS by adding oxaliplatin to fluoropyrimidine. And the risk of, the risk reduction of death is 16% in MOSAIC, 12% in NSA-BP and 17% in Xeloxa. And further analysis has shown that improvement in overall survival was significant only for stage 3 colon cancers. So the current standard of care for stage 3 colon cancer is either FOLFOX or CAPOX regimen. Agents like irinotecan, cetuximab and bevacizumab have not shown significant benefit in localized setting. So moving on to the topic of duration of adjuvant therapy, the combination of 5-FU oxaliplatin leads to a cumulative toxicity in the form of sensory peripheral neuropathy. So various trials have tried to reduce this toxicity by reducing the duration of adjuvant therapy. So we have 6 studies which compared 3 months versus 6 months of adjuvant therapy. So these 6 trials have been examined prospectively by an international collaboration and it was published as the IDEA study. So we have 12,000 odd patients with stage 3 colon cancer in this study. So the results show that the 3-year DFS rates were similar between 3 months and 6 months of treatment. But the predefined non-inferiority margin was not confirmed in the overall study population. But the grade 2 or worse sensory peripheral neuropathy was significantly reduced. So it was 11% in the 3-month group, whereas it was 34% with the 6 months of treatment group. So when we look at the individual chemotherapy regimens, 3 months of CAPOX was found to be non-inferior to 6 months of CAPOX, whereas 3 months of FOLFOX was inferior to 6 months of FOLFOX. So the non-inferiority of the shorter regimen was seen for CAPOX but not for FOLFOX. So to further refine the adjuvant therapy in stage 3 cancers, they are further categorized into low and high risk groups. So the IDEA study conducted an exploratory analysis based on these risk subgroups. So in lower risk subgroup defined as patients with T1, T2 or T3 with N1 disease, 3 months of adjuvant therapy appeared to be sufficient when CAPOX was chosen. In higher risk group defined as patients with T4 or N2 or both, 6 months of treatment may be necessary. The 3-month CAPOX regimen missed the non-inferiority margin in this higher risk subgroup. So this is from the ESMO guidelines. So for low risk stage 3 cancers, we have option of 3 months of CAPOX or 6 months of FOLFOX. For high risk stage 3 cancers, they need 6 months of adjuvant therapy irrespective of the chemotherapy regimen chosen. So moving on to stage 2 disease. So there again we know that it is a subgroup with a variable prognosis. So they are further categorized into 3 risk groups, namely the low risk, intermediate and high risk groups, depending upon the presence or absence of the major and minor risk factors. So if there is no risk factor, they come under low risk category. So if there is presence of one minor risk factor, they come under intermediate risk. So if there is a presence of major risk factor or multiple minor risk factors, they come under the high risk group. So patients with high risk might be considered for addition of oxaliplatin based on the trend towards increased benefit. The IDEA trial again explored the optimal duration in this subgroup and it was found to be identical. So 3 months of CAPOX was found to be non-inferior to 6 months of therapy. So the MSI status again confers a better prognosis and less benefit to adjuvant therapy. So chemotherapy in this group should be indicated with caution and it should always be in combination with oxaliplatin. So for stage 2, low risk, they go into observation. For intermediate risk group, again based on the MSI status, so if there is microsatellite instability, they go into observation because of the better prognosis. And for patients with microsatellite stable status, they should receive 6 months of capecitabine. So for high risk group, again we have option of 3 months of CAPOX or 6 months of either CAPOX or FOLFOX, depending upon the risk factors present. So coming to the timing of adjuvant chemotherapy, it is again a matter of debate. Ideally, it should be not later than 8 weeks. A meta-analysis of 14 studies showed that a delay of more than 8 weeks in starting adjuvant chemotherapy is associated with a higher relative risk of death. But population-based studies have shown that adjuvant chemotherapy might still provide some benefit even with delays up to 5 to 6 months. So this slide is for metastatic disease, wherein patients have undergone resection of both primary and metastatic disease. So they should be offered 6 months of perioperative chemotherapy with either FOLFOX or CAPOX regimen. Moving on to surveillance for these patients. So for up to 3 years after surgery, clinical and CE assessment should be done every 3 to 6 months. Chest, abdominal and pelvic CT scan every 6 to 12 months. Colonoscopy every 3 to 5 years starting 1 year after surgery. Between 3 and 5 years after surgery, the assessment should be done every 6 to 12 months. The CT scan once every 12 months and colonoscopy again every 3 to 5 years. So looking at long-term implications, so the colorectal cancer patients form a chunk of the cancer survivors. So we need a good survivorship care plan which should focus on prevention of recurrent and new cancers along with intervention for cancer sequelae and the treatment. There should be regular assessment of medical and psychological late effects along with health promotion in the form of lifestyle promotion and comorbidity prevention, etc. So with this I conclude my talk. Thank you very much.
From the presentation that you made, one thing is apparent, that one of the key attempts that is being made by individualizing and personalizing the whole attempt to chemotherapy is to reduce the number of people who would require this and therefore limit toxicities, as well as the choice of drugs can often be curtailed depending on certain molecular and pathological characteristics. Thank you for the explanation. Having said that, it is also a fact that a significant number of the patients will, in spite of the chemotherapy that is given, they will progress to have advanced and metastatic disease, and some of them will be in fact diagnosed at a stage 4. So I invite Dr. Arif to discuss the new role of chemotherapy and immunotherapy, which is again a new buzzword, and what is their use in advanced and metastatic colorectal cancers. Dr. Arif.
Thank you, sir. So today I will be talking about metastatic colorectal cancer and also giving some brief overview of the molecular therapy which we are using in the metastatic colorectal cancer. So starting from the survival, initially the survival in metastatic colorectal cancer was around 6 months, and with the advent of the immunotherapy and targeted therapy, and also by doing the broad molecular profiling, we have improved the survival to 25 to 30 months now. So the management of metastatic colorectal cancer starts with first line therapy. Usually it's a doublet chemotherapy with targeted therapy. After the induction, we go on to maintenance, followed by either reinduction or to moving to the second line therapy, followed by third line therapy. So by doing all this and sequencing the therapies, we have improved the survival to close to 3 years. So what are the first line strategies we adopt? So it depends on the side of the tumor, the location of the tumor, whether it is right sided or left sided, and also we send for the molecular profiling, that is we look for the genomic alterations in the cancer. So once we send it, the most common mutations which we look for are KRAS and BRAF. So the other things are still we don't have drugs to target them. So after deciding on the side of the tumor and also the genetic alterations which are found, we proceed with the planning of the systemic therapy. So the standard strategies are, we start with doublet chemotherapy. We add a targeted agent to this backbone, chemotherapy backbone. The targeted agents which we have got are mainly anti-VEGF and anti-EGFR agents. So which targeted agent to use depends on the sidedness of the tumor. If it is right sided, we use anti-VEGF, which is preferred, and if it is left sided, we prefer anti-EGFR. And if the molecular status is KRAS mutant, in which we use anti-VEGF, and if it is KRAS and BRAF wild, we use usually the anti-EGFR agents. So what factors decide the chemotherapy and targeted therapy to be used, or based on the what are the aims of the treatment? It is, if you are aiming at rapid tumor shrinkage and cytoreduction, we usually use a chemotherapy doublet with anti-EGFR in the RAS wild type. If it is disease control and the aim is to prolong the survival, then the chemotherapy which we use are mainly doublet and with anti-angiogenic agents. So what will be the sequence? If we start with EGFR, we have to follow with VEGF in the RAS wild type. If we start with the anti-angiogenic, then as keeping the EGFR for the second line would not help. So many of the trials have shown that following anti-angiogenic agents with the anti-EGFR doesn't help. So in RAS mutant, it is only the anti-VEGF agents which we use. First line bevacizumab, followed by in the second line with other VEGF agents like ramucirumab, aflibercept, or the bevacizumab also can be used beyond progression. So why is it important? Because the molecular profiling is important because we identify different molecular subgroups like BRAF, KRAS mutants, and the double wild type, which have different prognosis and different survival. As we can see from these curves, so BRAF is the very poor prognostic subgroup which has a survival of close to 1 year, and KRAS mutant is close to 2 years, and we have double wild type which are BRAF and KRAS wild which have survival close to 3 years. So apart from the RAS and BRAF, nowadays we are also considering a broad molecular profiling which picks up the mutations in other genes, like we are looking for MSI and HER2 and KRAS G12C, because we have got drugs to target these genomic alterations and mutations. So coming to BRAF mutated CRC, so the BRF is a part of the MAP kinase pathway. We can't use a single agent BRAF agents because there is a rapid development of tumor resistance if we singly inhibit the BRAF. It has to be combined with MEK or anti-EGFR agents to produce a stronger control over the tumor. So coming to this study, the TRIBE study, which compared FOLFIRINOX with bevacizumab comparing with the FOLFIRI with bevacizumab. In this study, there were some patients which had BRAF mutations, and which showed that triplet plus anti-angiogenic agents are more important in controlling the tumor and prolonging the survival. But this was followed by TRIBE2 trial, in which it was showed that triplet is not always needed, doublet is enough for the BRAF mutated colorectal cancers. As we can see from the subgroup analysis of around 115 patients, in which both triplet and doublet were almost producing similar outcomes. This was followed by FIRE 4.5 trial. It compared in the first line anti-EGFR with the anti-VEGF combined with the triplet therapy in the BRAF mutated population. It showed that in the first line, anti-VEGF is better than the anti-EGFR agents in prolonging the PFS and also the OS. So this is the BRAF signaling pathway. We usually combine BRAF inhibitor with the MEK inhibitor or with the anti-VEGF agents, or we can also combine all three and treat it. So this was the Beacon study, which studied in the second line the combination of BRAF, MEK and anti-VEGF, anti-EGFR, or a doublet agent BRAF with anti-EGFR compared to the control arm with the doublet chemotherapy with the anti-EGFR. So this showed that the overall response rates were improved with the triplet and the doublet arm as compared to the control arm, and also the survival was significantly improved in the triplet and doublet arm. So these BRAF combined with the anti-VEGFR, anti-EGFR agents can be used in the second line treatment of the BRAF mutated colorectal cancers. This was another study, the ANCHOR study, which was a open label phase 2 study, single arm study, which was done in the first line. It involved around 90 patients, in which the triplet regimen of BRAF with MEK inhibitor with the anti-EGFR was studied. It showed a good responses, which was quite similar, the survival was quite similar compared to the conventional doublet chemotherapy with anti-angiogenic agents. So to summarize, so BRAF mutated population is a very poor prognostic subgroup. It needs a targeted agent to produce good outcomes. The survival is close to 10 to 20 months. All triplet therapy is not always required. The doublet with anti-angiogenic agents can be used in the first line. In the second line, we can consider BRAF with anti-EGFR. So if the patient has limited colorectal metastasis to the liver, they can also be considered for surgery. And how to best sequence is still a matter of debate, and we need some robust first line studies to know which treatment is better and how to sequence these agents. So coming to MSA high population, this is another molecular subgroup for which we have got the targeted treatments. So the pembrolizumab was compared with chemotherapy in this MSA high population. It prolonged both the PFS and also the OS was numerically improved, though it was not statistically significant. So nowadays in the MSA high tumors, we don't use chemotherapy. We start with immunotherapy, and later on, once the patient progresses, we can give chemotherapy, reserve the chemotherapy for the second or third line. So initially we had RAS wild type, RAS mutant, and other subgroups, but now we have got BRAF mutation subgroup and also MSA high the subgroup for which we have got targeted agents. So if the patient has both MSA high and BRAF, which commonly occurs, then we can start with the immunotherapy, later on give the targeted therapy in the second line and reserve the chemotherapy for the third line. So we have got a lot of options now with respect to the targeted agents which we can use because of the many of the molecular profiling we are doing, and we are picking up a lot of other mutations which can be targeted with drugs. So these are the various molecular subgroups which we find at the baseline, like KRAS mutated, BRAF mutated, HER2 amplified tumors, NTRK fusion, colorectal cancers, MSI high tumors, and TMB high tumors. So what were the options for the HER2 amplified colorectal cancer? Usually the chemotherapy with the anti-HER2 agents doesn't work better in this patient population. So these are some studies with the dual anti-HER2 blockade with Lapatinib, Trastuzumab, did improved responses. These are some initial phase 1, phase 2 studies which showed responses with the dual HER2 blockade. And also we have got newer agents like antibody drug conjugates like Trastuzumab deruxtecan, which is showing a promising efficacy in these HER2 amplified tumors. So what about the KRAS G12C mutated population? We have got some agents to target this like sotorasib, which is a KRAS G12C inhibitor, which showed improved responses in the phase 1, phase 2 trials. And also we have got some the Crystal 1 ongoing study, which is also a phase 2 study, which showed better responses when we can combine this KRAS G12C with anti-EGFR agents. The NTRK fusion positive cancers, though this constitutes a very rare population subset where these mutations are rarely identified, we have got targeted drugs for it, which are larotrectinib and entrectinib. So beyond second line, what we use is usually trifluoroetine tipiracil like TAS102 and also regorafenib. These also produce a meaningful improvement in the progression free and the overall survival. To conclude, so colorectal cancer is a paradigm of multidisciplinary oncology. Surgery has to be attempted if all lesions are resectable. Local regional treatments have to be discussed, and including in the intra-arterial therapies. Doublet or triplet chemotherapies with targeted agents are the first line choice of the management. In the second line, protocol can be generally switched, and we can sequence the treatment. If you use the anti-EGFR, we can change it to anti-VEGF. So there are different molecular subtypes which are identified and which can be targeted, which has improved the meaningful overall survival. Thank you for participating in this activity. I thank you for your kind attention.
Thank you, Dr. Arif. I think that was a very, very lucid and clear exposition of where we are in treating metastatic colorectal cancer. I have to say, if we have a time machine and we transport somebody from 2010 to today, in just 10 years, he would not be able to understand the kind of changes that have happened in colorectal cancer. That last slide alone is something that would have been unheard of or unthinkable probably 10 years back. And again, underpinning this is, as usual, like most cancers, our understanding of personalized therapy, our understanding that using targeted molecular agents, doing targeted sequencing to find molecular targets, that is the way to go forward for all malignancies, including colorectal. Plus a better understanding of how to sequence the available drugs, how to use the available targeted therapies, and we are now looking at a scenario where the expected median overall survival is crossing close to 3 years. So colon joins lung cancer, breast cancer and other cancers where we are now seeing a long survival. I think nothing is more emblematic of the change in colorectal cancer than the KRAS G12C. For long it was considered that KRAS is an untargetable mutation. The last 3 years have seen a great degree of research going into the molecular structure, and after that we found one drug that actually would be able to block the G12C. And now a lot of activity is ongoing trying to find drugs for pan-RAS mutants and other mutations. So as they say, watch this space for more. Definitely the treatment of colorectal cancer is only going to get better and better. As Arif said, it's becoming more complex, and yet for an individual patient there is hope that we will be able to prolong the survival for even metastatic colorectal cancers. With that, we come to the end of today's session on colon cancer, and as the slogan says, #care for colon. Colorectal cancer is something that can be treated, which needs to be addressed early, and which has enough and more treatment options available, which need to be used in the right way, in the right sequence. So good evening everyone, and thank you once again for your listening.